Start.
Okay, today we'll discuss about the Fontan circulation. Uh, just a second. Okay, so we'll go through the this various content of this discussion. So first of all, in normal, what happens is there is a double circuit. Means systemic and pulmonary circulation are powered by a double pump. Means right side of the our heart pump to the pulmonary artery and left to the systemic heart. So many complex cardiac malformation has only functional one ventricle. Like what we say, whenever there is a possibility of biventricular heart, means both chambers are well formed, we try to do ICR. When this ICR is not possible, only single ventricle is there, like in cases of hypoplastic left heart, only right ventricle is formed, or hypoplastic right ventricle, only left ventricle is formed. In that case scenarios, we can't do a biventricular or complete intracardiac repair. In this case, we go through a Fontan physiology or Fontan surgery that maintains the pulmonary blood flow. So in subsequent time, we'll see how it maintains the pulmonary blood flow. So it is done in a univentricular heart. Maintain a systemic and pulmonary circulation, not connected in a series but in a parallel. Major disadvantage is atrial desaturation, chronic volume overload to the single ventricle, in due to course of impaired ventricular function. What happened in univentricular heart, that is described. Univentricular heart leading to arterial desaturation, chronic volume overload. So to prevent this, we'll do a Fontan's operation. So what happened because of chronic volume overload in a single ventricle? There is a dilatation of the atrium and ventricle, leading to the dysfunction, eccentric hypertrophy, spherical remodeling with reorientation of wall fibers, annular dilatation causing progressive AV wall reagitation. So there is a time period for that. It's not like that ki whenever a single ventricle comes, we can do a Fontan surgery or a step one like hemi-Fontan. Why? Because of this thing. Ultimately, because of chronic volume overload, there is a dilatation, changes in the chamber, orientation changes in fiber, and ultimately AVVR. So once these changes happen, we can't do a Fontan. So hemodynamics problem, what happened in univentricular is there is a lack of interventricular coupling, means one of the ventricle is not formed well. The volume overload of single ventricle, the mechanics of the RV and LV will different in univentricular heart. The morphological and functional state of the AV wall is changed. Might the degree of mixing within the systemic ventricle will be there. Pulmonary vascular resistance because of high pulmonary blood flow might be changed, and there might be changes. There might be a LVOTO or RVOTO like PS or aortic stenosis. These all are the hemodynamic parameters that will affect the our repair condition. So coming to the topic per se, the Fontan concept. So this was the surgeon Francis Fontan who first done the Fontan operation, and this Fontan operation by his name only, and done in a patient in tricuspid atresia. Okay. Uh, s- so Fontan circulation is what the systemic venous return enters the pulmonary circulation without interposing the ventricle. All shunt and venous, atrial, ventricular, arterial level are interrupted. Thus, the systemic and pulmonary circulation are series by the single ventricle. So, I think you understand what we did here. We connected all systemic veins to the pulmonary circulation directly. We disconnected the ventricle. We closed the ASD, if you suppose ASD is there, and we close the tricuspid wall also, annulus. So, no blood will go from RA to RV. So blood will go from systemic vein from IVC to SVC to the PA. How it goes, we'll see in a subsequent section. So advantage is what? There is a near normalization of arterial saturation. Also, there is a abolishment of chronic volume overload to the single ventricle. But cost of such circulation, there is a chronic venous hypertension and congestion, because the systemic venous pressure is around 10, less than 10, when PA pressure may be 10, 12. So there is a venous hypertension, and that might lead to a congestion like pleural effusion, pedal edema, so many things, and also lead to decreased cardiac output. Now, cardiac output totally depend upon systemic venous pressure. or pulmonary pressure, because systemic venous pressure now pumping the blood to the pulmonary circulation, that from pulmonary circulation coming to the left heart. So decreased cardiac output both rest and during exercise, and cardiac output no longer determined by the heart but by the transpulmonary flow that is regulated by the PVR. So first, the original Fontan. We'll see how modifications are done in the Fontan operation. So first one is the original Fontan. This is done by the classic Glen with the end-to-end anastomosis of SVC to the RPA, then end-to-end anastomosis of RA appendage to the proximal end of LPA by means of aortic homograft. As we can see in the pictorial depiction, what happened? SVC is connected by end-to-end to the RPA, and IVC blood is routed to the LPA via right atrial appendage. And there is a closure of ASD if any ASD is there. Also, there is a closure of tricuspid valve. So this RA will act as a one single chamber. Okay. Also, there is a ligation of the MPA. So blood will go directly to the IVC blood go to the left side, and SVC blood go to the right side. This was the original Fontan operation, which was described by Francis Fontan, which was done in a tricuspid atresia. In that case, the tricuspid was already atretic. At that time, the RA contraction were thought that to be important in a pulsatile assistant to the pulmonary circulation. Means RA is a contracting structure, so it will help in a maintaining the forward flow. It became evident later that inlet and outlet valve were more problematic than the beneficial. What happened? This right atrial appendage was associated with the homograft. Means Francis Fontan used the aortic homograft. So this was associated with the inlet and the outlet. Later, this was associated with the problem. What problem they arises, we'll see in subsequent. So because of that, there is a Kreutzer modification in 1973. Described the connection between the RA appendage and the MPA, accomplished by means of pulmonary homograph or patient's own pulmonary annulus, but without wall. The homograph at the IVC right atrial junction, Glenn shunt was not performed. It was flowing passively directly into the lung without being pushed by the heart. Same way, every Fontan circulation is passively flowing, not pushed by the heart. In Kreutzer modification, what he did, the SVC, IVC both are connected to the RA only. He not transected the SVC, IVC. What he did is just right atrial appendage is connected to the MPA, and right atrial exit point, like from the tricuspid wall, is closed. So it's a blood from the SVC, IVC is going towards the MPA. But without wall. Previously, by Francis
Sir,
Fontan, it was. Yes,
original Fontan SVC was connected to RPA, na? No?
yes. SVC to the
You told
RPA,
connected to RA.
and RA from right atrial appendage connected to the LPA.
That is IVC.
Yeah, IVC blood only going, but directly he not transected the IVC. He uses the right atrial, means right atrium. He thought the right atrium is the contracting structure, it will maintain the forward flow.
No,
But
no,
that,
no, you told both SVC and IVC was connected to RA in original Fontan. Is it correct, or SVC is connected to
no,
RP?
no. SVC only connected to the RPA.
Okay. Please go ahead.
But what was I was telling? This was graft. What he put now, what is associated with wall. This wall was problematic. That's why Kreutzer modification he came. He uses the pulmonary annulus without wall, but he not transacted any SVC, IVC, just right atrial appendage to the MPA. So what we call as a classical Fontan. Classical Fontan is with the wall conduit, as already I described. SVC was connected to the RPA, from the IVC, from right atrial appendage to the LPA. But later on, the classic Fontan, Kreutzer modification, he used uh, without wall. Like in classical Fontan, ASD is closed, tricuspid wall is closed, SVC blood is directed to the RPA, and from IVC through the right atrial appendage goes to the LPA. Later on, subsequent modification came by the D level in 1987. He described a lateral tunneling. Why? Because after many years, the right atrium start dilating, and it's progressive dilating. Why? Because of the turbulence of blood as it was arriving from the vein coming from the body into the collecting chamber. Because of turbulence of the blood in the RA, it causes dilatation, and because of dilatation, it leading to the arrhythmia and clot formation. So in lateral tunneling, what happened? As we can see, the SVC it is attached to the upper part of the RPA, like in this case we can see, and the collecting chamber inside the RA it's separated from the artificial material like dicron graft and suture inside the RA, so that the IVC blood directly goes inside the RA and draining into the PA. So this operation is called as a lateral tunnel or TCPC, that is total cavo-pulmonary connection. Lateral tunneling. This was used. What's the use of lateral tunneling? By performing the anastomosis between the SVC and RPA and earlier age as an intermediate step decreases the mortality and morbidity, achieving the final Fontan circulation. What happened? Initial whatever modification I told, this was all our single stage. This was associated with high mortality and morbidity. Later on, subsequently, they thought creating a stepwise, like first step, hemifontan, that is bidirectional glen, and followed by completion of fontan by connecting the IVC blood to the PA, was associated with a decreased mortality and morbidity. So, followed by they come by extra.
Is there any term called unidirectional glen?
Yeah, unidirectional glen means what? Whenever one SVC we attach to the RPA and side anastomosis. Bidirectional glen is both way we attach. Suppose both SVCs are there, like LSVC, RSVC, that we are attaching.
Okay, bidirectional is both LSVC and RSVC.
Yes.
Unidirectional glen, no, you just connect the SVC to RPA end to end.
Yes.
Okay, this is unidirectional or classical glen.
Unidirectional.
Bidirectional, you just connect the end of SVC to the side of
both the. I mean, its blood will go to both RPA and LPA.
Yeah, that's why blood will go to both RPA and LPA.
Okay.
I think it is end to end versus end to side anastomosis.
End to side anastomosis. End to end is
unidirectional. Not LSVC, RSVC.
Oh no, LSVC, RSVC is not. No, this one.
No,
end
that is
to
not
end and end to side.
Bidirectional is termed based on end of SCC to side of pulmonary artery. So that blood will go into both LPA and RPA. In classical used to go, blood used to go from SCC to RPA.
End to side anastomosis to the main pulmonary artery is kada bidirectional glen.
No,
Means
that's what Sham showed the image. Na?
It going to both.
RPA.
Going to both the lungs, that is bidirectional.
Sham, నువ్వు ఆ ఇమేజ్ చూపించావు కదా ఫస్ట్ ది ఫాంటన్ లో క్లాసికల్ గ్లెన్ చూపించు
యూనిడైరెక్షనల్ గ్లెన్
ఇది యూనిడైరెక్షనల్ క్లాసికల్
ఇది యూనిడైరెక్షనల్ గ్లెన్
ఇది కాదు
ఇది కాదు
ఇది యూనిడైరెక్షనల్ SVC to RPA end to end SVC to RPA, that is classical or unidirectional glen. Bidirectional అంటే SVC ని
got it, right.
Yeah, you don't like side of pulmonary artery, so blood will go both into our right side and left side pulmonary arteries.
Right. So apart from the lateral tunneling, the next is the using the extra cardiac conduit. This is the recent modification. In this case, the intra-arterial routing of venous blood by insertion of external conduit. So advantage of what? It require a minimal means time and no cardiopulmonary bypass. It the requirement of right arterial incision and the sutures are less, and so that the risk of injury to the SA node and post-op arrhythmias are also less. These are all the advantage. The disadvantage of this is what? There is a no growth potential and the risk of obstruction by the thrombus and the neointimal hyperplasia. Ideal size for this conduit size is given as the 18 mm. In lateral tunneling, there was the advantage of what? There is a potential for the growth. As the child grows, there is a potential to grow, growth can be occur.
Now in lateral tunnel, will you make it as a tube or just a conduit? Like one part only closed?
Like a baffle, you can say.
Baffling.
Okay.
Means using the one side of the RA and other side of the wall by putting an artificial material.
Okay. And okay, driving the blood to that.
Yeah, just we are diverting the blood directly to the SVC. What,
Okay.
like, we are not want to use the full RA. We want to use some part of the RA, because whole RA, when we are using, it was associated with the dilatation,
Yes,
thrombus
sir.
formation. So we are using some part of RA so that the growth potential are also there. Okay, so Kawashima operation, this is done in cases of interrupted IVC, in which the IVC is continuing as a azygous vein and draining into the SVC. So in this case, what we do is, if any patient is having this condition like interrupted IVC, we do a Kawashima operation. In this case, we do a bilateral cavopulmonary anastomosis, leaving behind the hepatic vein draining into the RA. So in interrupted IVC, the azygous vein draining into the SVC and hepatic vein directly drained into the RA. So what we do, we leave behind the hepatic vein which draining in the RA. We do just a bidirectional cavopulmonary anastomosis. If RSVC is there, LSVC we attach to each side. So this is Kawashima operation. Now come fenestrated Fontan. This
But
was
in
described.
Kawashima, because
Sham.
hepatic veins are draining into RA, we cannot
Mhm.
close the RA exit, no?
No, it will be there. Will
Okay.
Then
not
how
close.
it will be connected to pulmonary circulation?
What?
How it is connected to
Sham.
pulmonary circulation?
We leaving the RA as it is. From SVC and IVC from the upper end we transacted, that we attach to the RPA and LPA or the bidirectional gland. So in this case, ideally speaking, the already IVC by the continuation of the azygous is going to the SVC. So most of the blood is already going to the SVC. Only hepatic part is draining into the RA. So as much, there is not much blood is remaining to drain, to come to systemic circulation or systemic venous circulation. Here
Sham.
IVC directly going to the upper side, na? So blood is already going. So if we see, we already did Fontan, means half of the Fontan is already done by the nature. Just we are attaching the gland now. Yes,
Okay.
Sagar.
Okay. No, blood from hepatic vein goes into RA. From RA, where it goes, like, what is the circuit?
I think through
Sir,
ASD.
ASD will be there,
ASD.
ASD will be
ASD.
That's why it ended
close.
systemic circulation.
right?
Okay, okay. Okay.
Now comes the fenestrated Fontan. So why fenestration? Because in any patient who's having high RA pressure and low cardiac output, it associated with the increased mortality. So we are creating a shunt-like phenomenon whenever there is an increase in Fontan's pressures. So there is a window to pop off this pressure. So allow, what is the advantage? It's allow a adequate cardiac output by right to left shunt. It reduces the incidence or duration of post-op pleural effusion and lowers the early surgical mortality. But disadvantage is there is a arterial desaturation. There can be a paradoxical embolism, and further in future we might need to close this fenestration. So again, re-intervention is required. So in fenestration, what we do a small opening is created between the conduit and RA. Its function as a pop-off wall to prevent the rapid volume overload to the lung, limits the caval pressure, increase the preload to the systemic ventricle, and increase the cardiac output. Cyanosis may be there. So this is mainly used in cases of borderline cases, like like if the PA pressures are more than 15, or some books say more than 12 also, is the relative contraindication to do Fontan. Means it's associated with high morbidity and mortality. In that cases, like borderline cases, if we do a fenestration, so early what happens is the blood is going towards the PAs now. Previously the blood was not going, or it was mixing. Now full of the blood go to the PA. So suddenly there is volume overload failure, and if the systemic venous hypertension happen, so ultimately it lead to pleural effusion, edema, so many complications. So to avoid that, fenestration is created. but at the cost of cyanosis.
అది మీన్
Fenestration
ప్రెషర్
ముందు ఇంక్రీజ్ ప్రీలోడ్ టు ద సిస్టమిక్ వెంట్రికల్ అంటే
increase means what happen if the wall of the blood is like systemic hypertension is there, cardiac output is ultimately decreased if it is a Fontan is failed. So by giving the pressure off to the RA, we are increasing the preload.
ఇంక్రీజింగ్ ద ప్రీలోడ్ బై ఇది కొంచెం
పల్మనరీ హైపర్ టెన్షన్ ఉంది ఆ పేషెంట్స్ కి ఇప్పుడు
Yes.
టూ అవుట్పుట్స్ ఉన్నాయి కదా, ఒకటేమో
Exactly.
త్రూ ఫాంటాన్, ఇంకొకటేమో త్రూ ఆర్ఏ. సో ఇప్పుడు పల్మనరీ
ఆర్ఏ
ఉంటే అది పాప్ ఆఫ్ అయిపోతుంది ఆర్ఏకి. ఒకవేళ లేకపోతే అది ఫార్వర్డ్ ఫ్లో తక్కువ ఉంటది కదా, వెళ్ళదు. సో ప్రీలోడ్ తగ్గిపోతుంది. సో పాప్ ఆఫ్ ఉంటే
Right.
ఆర్ఏ నుండి ఇంకొంచెం బ్లడ్ వస్తుంది అనమాట.
అడిషనల్ వాల్యూమ్
Yes, at most big means large volume is going to the PA now. Preload is like pulmonary hypertension is there, so already it will increase again. Means there is a pop up.
ఒక రోడ్ బ్లాక్ అయితే ఇంకో రోడ్ వెళ్తుంది అనమాట.
Yes.
ఓకే.
So fenestration decreases the post-op pleural effusion, may be closed after patient adapt to a new hemodynamics. Now fenestration are seldom created during the completion of Fontan because of improved patient selection preparation and improved staging. So this is a pictorial diagram. Like in this case, we created a one window or a pop-off here, fenestration. Like in this case, external conduit is used from IVC draining to the MPA, or then SVC connected to the side to end anastomosis here. Then again, after post-op is over, we can device close. This case, like in this case is shown. So what's the paradox of Fontan circulation? The paradox is the normal, the good hemodynamic state has a low pressure in IVC, less than 10, and mean pulmonary artery pressure is at least 15 mmHg. In Fontan circulation, there is a systemic venous hypertension and pulmonary arterial hypotension. So these two things create the pressure gradient, and this is the driving force for the pulmonary blood flow and assisted mechanically by thoracic muscle and respiratory function. So to understand, normally there is a low pressure in the venous system. Artery pulmonary systems are high, but in Fontan, systemic venous pressures are high, pulmonary pressure are low. That's why blood will flow forward. Okay.
Okay.
Yeah. So it should be emphasized that the driving force for circulating blood volume between the systemic and pulmonary vein is the pressure gradient between the central venous pressure and the LA, assisted mechanically by thoracic muscle and respiratory function. Same thing in previous slide what we told. It's the pressure gradient between the central venous pressure and the LA which drive the blood from the systemic vein to the PA. So this is a flow diagram, how it happens. Like in inspiration, there is a contraction of external intercostal muscle and diaphragmatic muscle. There is a creation of negative pressure intrathoracically and increase the intra-abdominal pressure. So it causes increased superior vena cava return and increased antegrade pulmonary blood flow. And constriction of abdominal vessel causes increased hepatic venous flow into the IVC, and ultimately it increases the antegrade pulmonary blood flow. Now we'll see the Joseph.
Now what happened during expiration?
Expiration, this will be not there. So the amount of blood will not go that much which goes in inspiration, but blood will flow in expiration also.
In expiration also the pressure gradient maintained in between systemic venous and PA.
Yeah, it will be more negative, the more blood will go in inspiration, but it is a continuous flow. It's not derived by any pump. So it's a continuous flow, but more in inspiration.
Continuous or pulsatile?
It's not pulsatile.
డిపెండెంట్ ఆన్ పల్స్ కంటిన్యూస్ ఫ్లో ఎరా పల్స్ స్టైల్ అనేది ఉండదు అంటారు కదా.
ఓకే ఓకే.
It's venous, not pulsatile.
జస్ట్ లైక్ ఎస్పిసి ఆర్ఏకి ఎలా డ్రైన్ అవుతుందో పిఏ కూడా అలానే డ్రైన్ అవుతుంది.
Exactly. But in inspiration it increases.
ఇన్స్పిరేషన్ లో మనం ఇప్పుడు ఇది ఎలా అవుతుంది అంటే కామర్ చాంబర్ పిఏ అయిపోయింది కదా.
Right.
లైక్ ఆర్ఐ ఇట్ ఈస్ నౌ రియాక్టింగ్, ఆర్వి అనేది లేదు కాబట్టి.
But what causes increase in central venous pressure?
Here told na negative intrathoracic pressure.
Blood will suck in.
That will be respiratory phasic, na?
Yeah.
నార్మల్ ఎక్స్పిరేషన్ లో
That occurs during
అలా కాదురా
inspiration. Okay, okay.
అలా కాదురా సమరా. ఇప్పుడు ఆర్ఏ ప్రెషర్ ఎక్కువ, ఎస్విసి ప్రెషర్ ఎక్కువ నార్మల్ డ్రైనేజ్ లో. మనకి ఎస్విసి
RA.
కానీ ఐవిసి కానీ ఆర్ఏకి ఎందుకు
RA.
నార్మల్? ఆహా, ఆర్ఏ
Sorry,
డ్రైనింగ్ ఎందుకు అవుతుంది? ఆర్ఏ ప్రెషర్ ఎక్కువైనా ఎస్విసి ఐవిసి ఎందుకు డ్రైన్ అవుతుంది?
okay. Valve, అది valve mechanism.
వాల్ మెకానిజం కాదు, 3 ఫినామిన్స్ కదా. ర్యాపిడ్ ఫిల్లింగ్ ఫేజ్ కదా, ప్యాసివ్ గ్రావిటీ ఫినామిన్ అది.
Okay.
నీకు ఐవిసి రూటింగ్ అనేది ఆర్ఏలోకి ఎలా ఉంటుందంటే బ్లడ్
విసా
అనేది
ఫ్రాంటే
డ్రైనింగ్ అలా. ఆ
విసా ఫ్రాంటే మెకానిజం. బ్లడ్ ఎల్వీలో నుంచి
ఉమ్.
అయోటాకి వెళ్ళినప్పుడు సక్ అయింది రైట్ సైడ్ చేంబర్స్ నుంచి ఎల్వీలో.
రైట్ సైడ్ సక్ అవుతాయి
And that
చాంబర్స్
is-
మోస్ట్లీ.
Right.
అదంతా ప్యాసివ్ ఫినామిన్ కదా. సేమ్
ఇన్స్పిరేషన్ లో కూడా అంతే, ఎస్విస్ నుంచి సక్
Jugular
అవుతుంది
venous
అని
pressure
చెప్తున్నారు.
inspiration లో ఇంక్రీజ్ అవుతుంది కదా,
Okay.
అంటే వెనస్ బ్లడ్ ఇంక్రీజ్ అవుతుంది, అందుకే సేమ్
వాడనేది
మెకానిజం.
సమరా ఏదంటే ఇన్స్పిరేషన్ మనకు అర్థమైంది కదా. నార్మల్ ఎక్స్ప్రెషన్ లో కూడా
Now,
బ్లడ్ అలా
PA pressure is
కంటిన్యూస్
usually more than venous pressure, no?
ఉంటుంది కదా నార్మల్ గా.
నార్మల్, దానికే మనం పారాడాక్స్ అని పేరు పెట్టినాం.
అది దాని మెకానిజం ఏంటండి?
మెకానిజం ఏంటంటే
ఆహా.
So it is directly connected to PA.
కాదు,
దాంతో సిస్టమిక్ వెనస్ హైపర్ టెన్షన్ అవుతుంది.
PA pressure when it is connected to the right
RV.
ventricle, it is more. But
More.
if it is
Yes,
అదే
connected only to the systemic
only
veins,
to the SVC,
it
it will
will
be
have
low.
a relative pulmonary hypotension.
Okay.
This
So
is
that will lead
paradox
to
of
gradient.
Fontan circulation.
Okay.
అదే చెప్తున్నారు కదరా. ఇప్పుడు ఇది మనం దీన్ని ఎలా కంటిన్యూ తీసుకుంటే ఆర్ఏలా తీసుకోవాలి, పిఏలా తీసుకోకూడదు. నీకు ఆర్ఏ అనేది
Okay.
ఎలా ప్యాసివ్ ఛాంబర్, దీన్ని అలా తీసుకోవాలి.
Okay.
So that's why
Next.
it's called as a Fontan paradox of Fontan circulation. 10 minutes only. We have to relog in likely.
ఓకే, మీరు కంటిన్యూ చేయండి, నేను అయిపోయినాక రీలాగిన్ అయ్యాను.
Oh. Okay, so Josette, 10 commandments. So what are the ideal patient for the Fontan? Age should be more than 4 and less than 15. Should be normal sinus rhythm, normal systemic venous connection, normal right atrial volume, mean PA pressure should be less than 15, pulmonary vascular resistance should be less than 4, adequate size PA to compare to the aortic size should be more than 0.75, LVF more than 60%, competent mitral wall, there should be no AVVR, and absence of any PA distortion because of any previous surgeries. Out of which nowadays this all 10 commandments are not followed. Like RA is no longer used in our circuit, so right atrial volume is no longer considered. Like that, other features are also there, but this was the previously described 10 commandments. Now we'll see the indications. What are the indications for the Fontan? So any cardiac malformation and single functional ventricle resulting from a dysfunctional heart wall or absent or inadequate pump chamber, like most common congenital heart disease in which Fontan circulations are done, like tricuspid atresia, pulmonary atresia with intact ventricular septum, hypoplastic left heart syndrome, double inlet ventricle, or DTJ is never palliated with the Fontan circulation to be remembered. DTJ, we have a various other operations that we'll discuss in next class. So before doing the Fontan, we have to do a pre-Fontan cath. In pre-Fontan cath, what all will we see? We'll see the patency of Glen. Means nowadays the Fontans are done in two stages. I have described in the next few slide. So the first stage is the hemifontan, that is bidirectional Glen. So we have to assess the first the Glen shunt through which we will assess the PA anatomy, PA size. Is there any distortion? Confluence is there or not? Is there any stenosis? And presence and absence of anomalous drainage of the pulmonary veins, like any significant veno-venous collaterals are there. Second, we have to take the IVC angiogram. So how many axes we have to take in this case? We have to take the Glen axis or the jugular axis, followed by a IVC axis, means so IVC for that femoral vein axis. Then in some cases, we might need to take the arterial axis also. So IVC axis will do, femoral vein axis will do a IVC angiogram to see for any interrupted IVC, stenosis, or any azygous vein draining. Then through arterial axis, we'll do a ventriculogram to see for contractility, AV regurgitation. More specifically, we'll want to see the end diastolic pressures. And then we have to take the oxygen samples to calculate the PVR, and finally a ventricular angiogram. So this is the same thing is described. Glenn Shen, we have to assess the PSI's confluence, IVC angiogram, then ventriculogram for any AV wall regurgitation, and the LA and diastolic pressures.
ఇందులో LA ప్రెషర్ తీసుకోమా?
LA pressure also.
అంటే జేఆర్ సార్ మనం చెప్పాడు కదా, ప్రీ ఫాంటన్ క్యాత్ లో ఎల్విడిపి ఎంత తీసుకుంటామో LA ప్రెషర్ కూడా తీసుకోవాలన్నది చెప్పాడు కదా.
ఎస్,
ఎందుకంటే LA ఎలా వస్తుందన్న వాల్యూమ్ ఎంత ఉందాన్ని బట్టి కూడా ఫాంటన్ సక్సెస్ ఉంటదని చెప్తారు కదా.
LA means generally a dilatation of any arterial ఉండంటే అది ప్రాబ్లమాటిక్.
అదే ప్రాబ్లం మొన్న చెప్పాడు కదా, మనం చేసిన ఫాంటన్ క్యాత్ లో LA ప్రెషర్స్ తీసుకోలేదు, ఇది ఇన్ఎడ్యుకేట్ అని చెప్తారు కదా. LA రూట్ కి ఎలా వెళ్తాం మరి? సింగిల్ వెంట్రుకలు ఉంటే LV త్రూగా వెళ్తారా?
LV త్రూకే వెళ్ళాలి, లేకపోతే ఐవిసి నుంచి మనం కూడా వెళ్ళచ్చు. సపోజ్ ఐవిసి ఆర్ఏ ఉండంటే, ఏఎస్డి ఉండంటే ఏఎస్డి నుంచి వెళ్ళే.
ఓకే, అంటే యాక్సిస్ అయితే ఫెమరల్ వెయిన్, ఆర్టరీ, జూగులర్ ద్వారా గ్లెన్కి వెళ్తారు.
పి అనటోమీ మనకు జుగులర్ తోనే తెలుస్తుంది, కింద నుంచి మనకు
జూగులర్ తోనే తెలుస్తుంది. నెక్స్ట్ ఫెమరల్ వెయిన్ ద్వారా ఐవిసి ఇంటరప్ట్ ఉందో లేదో తెలుస్తుంది. దాంతో పాటు ఆర్ఏ
వీడియోలో పెట్టిన మన ఈ రెండు దాంట్లో కలిసి చూపెట్టాం. మోస్ట్ ఇంపార్టెంట్ ఈస్ పిఏ ప్రెషర్ అండ్ PVR. PVR షుడ్ బి లెస్ దాన్ 4. PA pressure should be less than 12, what we in our institute JR sir said, but book said less than 15. With
PA pressure less than 15.
With increasing experience, criteria have been more flexible. Like pre-op impaired ventricular function and elevated pre-air pressures are also considering by giving a fenestration and all. So this is a Fontan cath. After Fontan cath, not before Fontan cath. In this, we can see the hepatic veins are draining into the IVC, and this is continuing into the RP and LP. Okay. What is the catheter course in this case? From where, what axis they taken?
Right femoral vein.
Yeah, it's a femoral vein only. From femoral vein IVC, through which we can see even fenestration also seen here. So is cardiac cath is always mandatory? No, we can do alternate.
Sham.
Yes.
Can you please show the image once?
Yeah.
What's meant by D here?
Device.
Like I showed na last
Device
case.
closer,
Yeah.
Okay.
Device
Fenestration. That's why any Fontan, if we want to do cath in Fontan, just we want to open the cath or we want to close the Fontan. Means want to open the Fontan fenestration or want to close the Fontan. In last one more image I also shown, that also we'll see. Okay, even we can do MRI. Pre-op cath only valid method to measure the PVR, abnormal aortopulmonary collateral, venous velar collateral. If there embolization we can do. So this is an upper hand for the cardiac catheterization over the MRI. So if someone asks why not MRI, MRI will not tell this case. PVR will not exactly we can calculate. Then abnormal venous collateral also we can't see, or we want to embolize, that also we can't done on MRI. So evolution, as I told, it's nowadays it's done in a 2-stage Fontan.
We know
so modern
collaterals ante దేనికి మధ్యలో ఉంటాయి?
Pulmonary vein and our vein systemic veins.
Okay.
ఇవి నాన్ హైలర్ ఎనాస్టమోసిస్ కదరా?
Yes.
నాన్ హైలరే కదా, చిన్న ఉంటాయి.
యాంజియోగ్రామ్ పెట్టిన ఒకటి
వెజల్ మీదుగా ట్రావెల్ చేస్తాయి కదా, హైలమ్ నుంచి రావాలి.
చాలా చిన్నగా ఉంటాయి.
I think better to start a new video.
ఓకే.
బా ఏం ఇంగ్లీష్ రా సాగర్, నువ్వు బాగా చెప్పావు.